context in which we are working right now in India. And as you know that in India, 3 years back, we started this national health insurance scheme called PMJ. And you don't need to go into the full form, but it's in Hindi. It's Prime Minister's Health Insurance Scheme. And so this is the scheme where we are implementing since past 3 years. And now we are looking at how we can improve. And provider payment mechanism is one of the very important factor into that. So I don't need to tell you that what is a provider payment mechanism, but for the benefit of my audience outside. So this is something where how do you pay the provider? How do you purchase the services? And this is a very important aspect for ensuring quality and also influencing the provider behavior. And also we are trying to see this as an indicator of measuring performance of the scheme. So of course, there are various provider payment mechanisms available, and it has to be contextual based on various things. So in India, we started with something, next time, which is called package rate. So, health benefit package, we call them. And this is something which is a very crude way of paying to the provider. So it's better than fee for service for sure, but it has its own challenges. So basically it's a bundled cost where we pay for a particular inpatient service, a fixed amount. And we started with certain set of package rates, which around 1400 odd, which we started with, and we keep changing it. And we have two kind of packages. For the surgical, we have packages where it's a single rate for the full surgery. So let's suppose if it's a hysterectomy, then the whole hysterectomy cost is one full cost. And for the medical, it's per day rate. So depending on whether you're admitted to ICU or where you are, it's a per day rate, which is all inclusive rate. And also what we did, that our benefit package is something which is a mix of negative and a positive list. So we have a positive list, but we also have a list of exclusion, and anything which is not in the exclusion, but also not in the positive list is still covered under the scheme. And the rate is not fixed. You have to fix the rate at the time of the treatment. So that kind of system we evolved under the scheme, and that's how we are paying to the providers. Next, please. So, and this rate includes all the charges related to the treatment, whether it's registration, bed charges, nursing charges, medicine, drugs, and even pre and post hospitalization expenses. Everything is covered, but there are challenges. Next slide. So we faced a lot of challenges where a lot of issues came from the providers and from the field that, you need to further work on it. A lot of people said that rates are very low, not for all the packages, but for many packages. And in many cases, hospitals said that if the rates are low, so we'll charge the patient, or they started doing it. So all these things were there. So we started working on improving and coming out with the next version. So we called the next version of our rates as HBP, Health Benefit Package 2.0, which came after around 1.5 years of the first edition of the package rate. Next, please. So the HBP 2.0 basically was that we found that, when we started the scheme, we started with something. We found that there were duplication happening. So the same package was in different specialties with different rates, in fact. So we also find the terminology was inconsistent. There were nomenclature related issues, and there were overlapping procedures which were covered in the National Health Program also, under PMJ also. And then there were issues of high-end diagnostic, which were not there. Certain treatment were not covered, so there was some fuzziness there. So keeping all these things in mind, we decided to shift to 2.0 HPP. Next, please. And that's where basically we increased the prices of many packages, we decreased price of some packages, we introduced new packages, we did some stratification of some packages, and some existing packages which were, either very old or defunct or not useful, we even removed those things. So we included a lot of new things, and we thought that this is an improvement over HBP 1.0, which it was, but still there were issues. Next, please. Basically, what we found that the idea was that now a lot of feedback is coming, and we are also learning, we are talking to different people. So we understand that, there are issues in the package rate kind of construct, where whether it's a simple surgery or whether there are complications in the surgery, the hospital gets the same money. So, many times we have seen a pattern where hospital for the simple thing, they will do it. But the moment it gets a little complicated, either they try to charge the patient, or they think that then they will refer it to another provider so that they can do, or it's a public provider they refer it to if it's a private one in the initial stage. So these things are coming. And also that we realize that, we need to improve. And when we try to think about future, the good thing is that we don't start from zero. So we don't start from something where from fee for service, we have to move to something else. we thought that we have to move from the current package rate to more nuanced system like DRGs and all. And in fact, NHA had some consultations where in fact Karen also joined for a couple of them, where experiences were shared from some countries. We also got some ideas from some other places, but we thought that at the 3-year anniversary event, it's a very good occasion actually to bring people who are masters or leaders in this field, hear from them, because they are not very closely involved here. So you all have a very, I will say, unbiased or objective opinion. And what do you suggest to us? How do we move forward? And this is, we also understand this is a long journey. It's not that it's a sprint or somebody is coming from UK, like it's not a 2020 match. So we have to see from that perspective. So I'll stop here, and please unshare the presentation. I'll stop here so that we can go to the panel members. This was a brief context setting which I just wanted to do. So I'll start with Jack, though his official legal name is John, as he said. So he's a senior advisor of financing and health insurance. He's a health economist with both research and operational experience, which is not very common for everybody. He's a old friend. He's a great guy. He has worked at several places, starting with World Bank, and last I knew he was with Bill and Melinda Gates Foundation before he left India. And he has written extensively on these topics. He has written on health financing, UHCs and all. I remember, in fact, there was a book of Jack with Cheryl also earlier on the provider payment mechanism. So I don't think he need too much introduction with a lot of people globally. So Jack, I'm very happy and honored that you are part of this session, and I hand it over to you, Jack, please. Thank you.
Nishant, thank you very much. And I'm very happy and honored to be at this session as well. And I'd like to congratulate you and everyone in India on the 3rd anniversary of PMJY. And let me just say that I joined you last year for the 2nd anniversary virtually, and I was quite impressed with how much progress had been made in the first 2 years. I have made presentations and I have been interviewed about how has PMJY done in its early years. I think you're off to a fast start. I've been very impressed. And so I'm very happy to see this sort of summary synopsis of what you've done over the past couple of years. And I do think that there are opportunities for improvement, but at the same time, I have no doubt that you can take those next steps. So I've just got a few slides. I'm not sure I'll take all of the time, but I think that I can open it up. I can open up the discussion and then turn it over to some of our other experts to do deeper dives. And I really want to talk about PMJY and how you might move to the next step, basically to some sort of case mix adjusted DRG system. Now, I'm having trouble moving the slides. Nishant, I'm having trouble moving the slides. Let me, should I
maybe unshare it? We will share it from our end, and then
okay, very good.
And you just have to say, and they will change the slide.
Yeah, thanks a lot. Yeah, I'm having trouble moving the slides, so.
You have to put the other, not this presentation.
So I do take your point about some of the issues around the package rates. I do think that was a good place to start, but I do take your point about the package rates, and I do think that one of the things that the DRG model could bring you is a better way to capture the complications and comorbidities. And if you could just go back one slide. You're on slide number 3. Now you're slide number 1, and go to slide number 2. Great. So here I have a little summary of the diagnosis-related groups. Started first in the US in the 1980s, so it's been around for about 25 years. It's not a new system. It was quickly picked up by the European countries, and it is now extended to most of the OECD countries, even countries like Korea, Japan, which have started to move into a DRG type of payment. If you want to choose the model that really captures or really promotes technical efficiency best, it would be the DRG model. And if implemented well, you can also achieve a great allocative efficiency. Technical efficiency being doing things right, and allocative efficiency being doing the right things. In other words, pushing services to their lowest possible, most cost-effective level. I do think that DRGs can facilitate competition across providers because they're no longer competing on price, they're competing on quality. And I do think that in that sense, they are very good in terms of improving responsiveness to patient needs. So I think the complications and comorbidity issue will be useful in terms of becoming a fairer payer to providers. So again, DRGs has many benefits. There are drawbacks. There are complexities, which I'll talk about in a minute. And there's also some risk of increases in volume. But I think you have encountered that with the package rate model. And there's also some danger of some fraud in terms of upcoding. But again, this is something that I think that PMJY, in listening to the second anniversary, you're already well adjusted, well acquainted with opportunities for gaming. And I think you have some good programs in place to guard against that. So I'm not particularly worried about that if you move to a DRG system. Next slide, please. So I mentioned that the OECD countries have moved almost entirely to the DRG model. And here we just have from WHO a little map of the non-OECD countries, the middle and low income countries. And you can see that there's it's East Asia, it's Eastern Europe, it's Latin America, and I've just listed on the left several countries that I've either worked with or been to where they are doing some form of DRG or using case mix at least to measure what's going on in hospitals and allocating budgets using the DRG case mix measure. Next slide. So people say to me, oh, DRGs are so complex. And so this slide really breaks it down into some basic component parts. And first and foremost, you need to think about your data collection system. And here again, PMJY has been moving relatively well. You've got a sophisticated information platform. You would use this information that you've been collecting through your claims system to then start classifying patients into groups. And then once that is done, you'd start allocating prices based on cost data. And then finally, you'd have to do some adjustments to come up with the final price. And here I would say that you need to go relatively easily and simply in the first couple of years. Don't make it too complicated, but let's talk about that a little bit in the next few slides. So if I could have the next slide. First and foremost, the information that you want to collect. Now, this is a list of the types of information that have been collected in different DRG systems. And across the top, the software, the classification scheme, often called the grouper, is listed. And you see groupers from the UK, you see groupers from the US, you see groupers from the Nordic countries, from Australia. And you can see that different groupers, different software programs require different types of information. But at the same time, you see that almost all of them have information that is common, a diagnosis, procedures. The Europeans tend to collect more in the way of facility variables than some of the other countries. But nevertheless, I think one of the things that you have to think about is the grouping, the classification, and the software that you might either build on your own or purchase and adjust for India. Next slide, please. So coming back, as I mentioned, once you develop the information, and again, I think you're off to a very fast start. I'm not worried about this information issue or this information collection, but you will have to think about your software, your grouping process. And you can, as I said, you can build your own, as we've done in the US, but it took us 10 years to do that. Or you can buy a software program, a grouper, and adjust it to your own needs. And I think that countries like Germany, I've seen some of the GCC countries now. The Australian grouper is a very popular grouper that is transparent, that has good, you can easily adjust it to your standards, to your protocols. And so you might consider identifying and choosing a particular software grouper that you can use for your patient classification system. And then I think the price setting, you have already started with the package rates to do costing. So again, you're at a relatively advanced stage, and I think you can expand that existing costing platform. Next slide. So this slide just says you don't have to go to every hospital in India to do costing. You can do a relatively small but purposive sample. And you can see here, if you take Germany, for example, a very small percentage of hospitals were actually examined, and costing information was taken to develop a very precise and a good DRG system in Germany. And you can see the same in some of the other European countries. So we're not talking about a big sample. We're talking about a purposive, a stratified sample that will give you generalizability in terms of your cost structure across hospitals in India, both public and private. Next slide. So once we've done the classification and once we've done the costing, then we need to do some final adjustments. And every DRG system has what we call exclusions, exceptions, and adjustments. And so, for example, will you include capital in your payment or not? This is an important part of how fair you are across public and private facilities. At the same time, capital is not always easy to include, and only a few countries, the US, Germany, Estonia, include capital in their DRG payment rate. You also may want to adjust for things like teaching. You also may want to adjust for things like ICU care, and some of your groupers, such as the Australian grouper, do that quite well. You already have some software programs built in to help that to be done relatively easily. And then I think you also need to think about cases where people come in for one thing. Let's say they come in for heart surgery, but then they develop other complications. They end up being in the hospital, not 5 days or not 10 days, but actually end up being in the hospital for 20 or 30 days. And these are the types of cases that we term as outliers, unpredictable cases that may need an adjustment for what has occurred after admission. So these are the kinds of things that you need to think about in the final stages. And I think Karen will go through these a bit more than I am. So we can go to the next slide. And what I would say is, I leave you with these kind of 4 areas that need to be addressed, right? The collection of clinical information, the selection of the software grouper, or the decision to build your own, which will take longer. If you want to build your own. You're talking about a couple of more years if you want to build your own. The collection of costing data, which you're already on top of in terms of having done that in the first couple of years of PMJY, the calculation of adjustments, and your base rates. Again, I think these are things that you've thought about and done with the package rates, so I don't see a particular problem. Now, I would caution you to keep it simple early on. Your adjustments, your exclusions, your different payment adjustments should be relatively simple. I was working in a country where there were 14 different adjustments, and that sends a very weak market signal to providers when you have 14 different adjustments. If I go to Con Market and I buy tea or coffee, and I take it to the counter to pay for it, and the person at the counter says, well, the price is this, but then we have 14 adjustments that have to be made. It's a little confusing to me in terms of how I choose the best coffee and tea. And I think with the same way here, you want to keep it relatively simple in the early years. Maybe you want to improvise or make further adjustments later, but go easy, keep it simple, and be clear and transparent in terms of your market signals to providers. Finally, the development of a phase-in strategy, extremely important. In Indonesia, they phased in overnight at midnight, and in Germany, they phased in over 10 years. So where do you go? Do you do it overnight or do you do it over 10 years? I think that most countries do it over 2 to 3 years, but this is a very important part of the move to DRG payment. So let me stop there. I know that Karen will go deeper in some of these issue areas. So let me stop there. And thank you again, Nishant, for the opportunity. Over.
Thank you, Jack, and very simple but very powerful. I think for everybody who is listening here in this room, also I can see people nodding because they could understand in a very simple way what you talked about Khan Market and coffee. So now I go back to Karen, and let me introduce Karen. Dr. Karen Brendenkamp is the lead economist and program leader of human development for Eastern Europe and is based in Kyiv, Ukraine. She is there with World Bank since I think almost 15 years now, and she has worked on a lot of complex sectoral reforms and lending activities across Europe, South Asia, Africa, East Asia. She has spent a lot of time in Vietnam and Philippines, even in India and Congo and Myanmar. So she's a huge expert, and we have already interacted with her a couple of times, have benefited from her very deep learning. So I'm very happy that she has agreed to be part of this panel, and she will be talking about these topics. And as Jack said, she will go a bit more deeper. So people who want to understand a bit more will be really benefited from her speech. So Karen, please. Thank you.
Thank you very much for that kind introduction, Dr. Jain, and good afternoon to you and to all the friends of PMJ joining us online from India and around the world. It is indeed a pleasure to be with you today on your 3rd anniversary. Congratulations on that. As you mentioned, I was also with you on your 2nd anniversary. And in anticipation of this presentation today, I've been catching up with some of my colleagues to learn about the developments since then. And as Jack said, yes, you have moved forward in some very impressive ways. And so what I've tried to do in my presentation is to gather together some of the global experience on developing a strategic phase-in for DRGs, but from that also select some of the specific experiences that may potentially be useful for you in PMJ as you embark on the very next steps. Could you kindly move to the next slide? Thank you. As Jack underscored in his presentation, DRGs are now being very widely used as a payment mechanism for hospital inpatient care in pretty much all developed countries of Europe, in large countries like China, also increasingly in countries of Eastern Europe, and many countries in Southeast Asia, such as Vietnam and the Philippines, are now in transition towards a DRG payment system. And certainly there must be some reasons for that. If you turn to my next slide, I'd like to share with you that we've tried to now gather some of the lessons learned from this global experience that we now have in DRG transition, drawing especially on the experience of 9 particular countries. This was a book co-authored with Sarah Bales and Christina Cahur, but also a number of practitioners and policy experts in provider payments, including Jack, who wrote the case study on the United States Medicare program. So what I'm going to be presenting today draws on the experience of these 9 countries, which include some of the trailblazers, the original pioneers in DRG development in the US Medicare system and in Australia. It also incorporates the experience of some of the mature DRG systems in Germany, Estonia, and Thailand, for example, but also the more recent examples from countries that have developed DRG systems with only the last decade or so, such as China and the Russian Federation. On this slide, I try to lay out the 8 key lessons that we've learned from these countries about transitioning to DRG payments. I will not go through each of these in detail. You have them there. I'm sure the slides will be circulated afterwards. But in the presentation today, I think I will elaborate on 4 of these. First of all, being clear about the purpose and the reason for moving to DRGs. Secondly, I will share some information about adopting a DRG grouper or building your own DRG grouper and factors to consider. Third, I'll look a little bit at phase-in strategies that have been used to move towards DRGs. And then I'll end with something on the time to be taken and the investments needed during that time. If we can go to the next slide, please. So first of all, in moving towards a DRG payment system, if indeed that is the direction that the PMJ would like to go in, I think you need to be very clear about your purpose and the reason for doing so, and figure out how to best communicate this to all relevant stakeholders. When we look across the 9 countries that we analyzed, we see a number of common themes and reasons for moving towards DRGs. These include the desire to have more efficiency in the health system, to have greater cost containment and sustainability, greater transparency and fairness in resource allocation, and better information on the basis of which hospitals and health systems can make decisions. In addition, there were some specific reasons for shifting towards DRG payments that had to do with the provider payment systems currently in place with the respective countries. So what we saw is that countries that relied on budget-based systems, such as global budget or capitation systems, were trying to offset some of the disincentives created by those systems. So they were seeking, for example, to try to incentivize hospitals to admit more cases or to treat more complex cases, rather than shifting those onto other hospitals. And because these were budget-based systems, when they shifted to DRGs, they implemented DRGs within global budgets, which helped them with cost containment. On the other hand, fee-for-service systems, if you can go back to the previous slide, often face the challenges of over-servicing, whether it be excessive use of diagnostic care or medicines, or longer than average length of stay. And so the fee-for-service systems were seeking to reduce this over-servicing and reduce the length of stay in hospitals. However, a number of these countries, when they shifted from fee-for-service systems to DRGs, did so without global budgets. And as a result, they continued to face challenges with cost containment. Now, of course, there are other systems, case-based systems, or perhaps even the package-based systems, such as that you have in PMJ. And if you can please stay on the previous slide. Such systems may also want to progress to DRGs. And if doing so, I would again recommend that that be done within a global budget. For them, there are reasons to make that shift. One is increased efficiency and fairness in financing, because in a DRG-based payment system where financing is very closely linked to the diagnosis of each patient and the overall case mix in the hospital, that is a more efficient and fair way to pay for the composition of the patient mix in the hospital. It also provides even greater transparency, and also interestingly opens up the opportunity for performance monitoring and benchmarking across hospitals of similar case mix. On the next slide now, thank you. I would like to talk about one of the critical first steps in shifting to a DRG system. Early on, you really need to establish a DRG unit, or at least a team, to drive the transition. Now, when Australia shifted to DRG systems, they had the Australian Case Mix Development Program, which was a very well-resourced, well-supported, and collaborative program that included experts and stakeholders from the federal government, from the states, from universities, from statistical agencies, from private hospitals and public hospitals and private health insurers. When Estonia moved to the DRG system, what they used was a team within the Estonian Health Insurance Fund. In Beijing's transition to DRGs, they had identified the Beijing DRG project team and then complemented that with the DRG Technical Review Committee to look very closely at the technical design decisions, such as reviewing grouping and relative weights. Now, eventually, as your DRG system matures, you will also need institutions that can maintain the DRG grouper. I think it's interesting to note when we look across different countries that these institutions are not necessarily located within a national Ministry of Health or a health insurance fund. So in Australia, for example, you have the Independent Hospital Pricing Authority, which is responsible for the regular revision and maintenance of the grouper, setting the standards by which costing is done, resolving disputes, and so on and so forth. But they are independent. Estonia is part of the Nordic Case Mix Center, where different countries collaborate on the combined Nord DRG, which is annually revised, and then the different participating countries use those annual revisions to the Nord DRG to inform their own respective DRGs. And in fact, a very interesting collaboration across multiple countries to get, if you want, the best expert opinion, where you may not have the sufficient diversity of broad expertise in any one of the participating countries. And finally, even in Thailand, we see that the Thai Case Mix Center is in fact an affiliated agency of the Health System Research Institute. Next slide, please. Moving on to the question of the selection of the grouper. And I think you can see from Jack's presentation that the grouper is really at the heart of the DRG classification and payment system. It's basically an algorithm. As we can see on the left-hand side of the slide, that's an example of the Thai DRG grouping algorithm for C-section, something of a flow chart. So this grouper assigns treatment cases, patients, to a DRG using the data on hospital discharges regarding the diagnosis and maybe secondary diagnosis, medical procedures, patient characteristics, length of stay, and so on. Moving to the next slide. And I think we've seen that when countries or health systems first contemplate shifting to a DRG system, the instinct is to build one's own grouper. And indeed, the US Medicare system, as the pioneer in DRG development, had to do just that. The Russian Federation, too, chose to build its own grouper. But the fact is that most countries don't do that, at least in the initial stages of DRG development. Most countries adopt their groupers, including high-income countries. So Australia adopted the HCFA DRG, which the US Medicare system had developed, and then later built the Australian DRG, and then later refined it further into the Australia Refined DRG system. When Germany transitioned to DRGs, they adopted the Australian Refined DRG system, and then later, at least grouper, and then later built its own. Thailand started off with the HCFA DRG, then moved to the AR DRG, and then later on built the Thai DRG. Beijing, they call it the BDRG, which follows the logic of the Australian Refined DRG. Kyrgyz Republic also adopted the HCFA DRG. I think you see where I am going with that. So I think there are many options to choose from, and so the question sort of arises of which grouper to adopt. I think the primary consideration is that adoption requires that there is a similar primary diagnosis and procedure coding system in both of these countries. If there is not, that's not necessarily an obstacle. So for example, Vietnam is intending to adopt the Thai DRG system. And so what they've done is to remap the Vietnamese procedure codes to the ICD-9 procedure codes that are used by the Thai DRG system. Other considerations could include the cost of the grouper, if it's being purchased, or its ease of implementation, and perhaps some of the similarities in the types of cases or resource utilization patterns that we see in the two countries. Third, I'd like to talk a little bit about the Drg Phase-in Strategy. One needs a phase-in strategy that manages the financial risk of providers and indeed of the payer, and allows both of them time to adjust to the new system. It's recommended, and we've seen that in many countries, that there is first a budget neutral phase. So for example, hospitals would report using DRGs, but not yet be paid by DRGs. And so one can use that reported information to conduct simulations of what the hospital revenues would potentially be, hypothetically, under the new DRG system. Hospitals could compare that to the resources that they are currently getting, and then start to figure out what adjustments they need to make in their clinical practice in order to manage within the future resource constraints. It would also be important to pilot to iron out operational issues. Now, in the Drg scale-up phase, when one actually starts paying by DRGs, there have been a number of ways to do it. Probably most common would be to scale up by geography, right? So the Russian Federation first started implementing DRGs in 3 regions, then 8 regions, then 63 regions, then 73 regions, and now implements in almost all of the 80 regions of the country. You can also scale up by hospital type, moving first with tertiary hospitals and then secondary hospitals, or vice versa. You can also scale up by partial DRGs, so only paying for certain types of cases by DRGs while others are still being paid by other provider payment methods. In the Beijing BDRG, they did a little bit of a blend of these two approaches. The first step was to move to 108 DRGs in 8 tertiary general hospitals, then to 300 DRGs in 39 tertiary general hospitals. And later they have the intention then to move from tertiary general hospitals to secondary general hospitals. In the next slide, I would also like to share 2 approaches in which DRGs were not scaled up by geography or by case type, but in fact implemented simultaneously countrywide, but in such a way that the system still managed to protect providers from financial risk. So in Germany, there was a phased convergence to a statewide base rate, and also eventually an approach where the statewide base rates were maintained within a narrow price corridor around a national price. So the first step was for hospitals to be paid using a hospital base rate. In other words, they were receiving exactly the same amount of money as they were before. And then progressively over time, they shifted towards a statewide base rate where a hospital was paid partially according to its own base rate and partially according to the statewide base rate. Eventually, convergence was achieved, and Germany now seeks to maintain each of the separate state base rates within a narrow corridor of around 1.5 to 2% around a national price. Estonia originally had a fee-for-service system, and so what they did after an initial phase of shadow funding with DRG, in other words, a budget neutral phase, was to pay hospitals pay each case predominantly using fee-for-service. So, for example, 90% in the first step, and partially using DRGs. And slowly they increased the percentage of each case that was paid by DRGs while decreasing the percentage that was paid by fee-for-service. So I think you can see from these examples that there are ways to manage the financial risk of hospitals in DRG transition. Next slide. And finally, we need to recognize that all successful DRG transitions take time. There is really so much to do. Technical design elements to decide on and develop, capacity building that needs to be done. Then there is the actual phasing in of DRG payment. And definitely a lot of time needs to be spent on regular stakeholder engagement. And even that step of phasing in DRGs can take quite a bit of time. Jack estimated around about three years at least. Certainly in our 9-country case studies, it averaged 5, but it could also be more. At the same time, because DRG transition takes time, one also needs to get going, including with a systematic action plan. So I think we should not delay. If this is the intention and the direction, let's get going, let's do it. And for sure, there are many friends of PMJ who stand ready to help you along the way. Thank you very much for inviting me, and I really look forward to following your future developments.
Thank you, Karen. Thanks for this excellent presentation. You know, it was short, but it was quite deep, I will say, because we were able to understand quite a bit about what is happening under the scheme, under the DRGs in various countries. And I think this is something which really is, will be a learning opportunity. And as you rightly said, that if we have to move, then we have to move fast. And of course, we have to do it in a good way. But I'm very happy, and I'm sure that there are a lot of friends who will be able to help as you offered, and as there are many more. So now I will go to the next speaker. I'm very happy and proud to welcome Dr. Cheryl Cashion. She's one of the global leaders in the field of health financing in UHC, working for more than 30 years. She's right now Managing Director of Results for Development, where we have worked very closely with R4D since it started almost, and I think Cheryl joined there in 2011. So she is one of the excellent facilitator I have seen. I have interacted with her in many meetings and conferences, and I was privileged to see her facilitating in various sessions. So I'm very happy that Dr. Cheryl Cashion is here, and she will be talking to us on this topic. So Cheryl, welcome, please. Thank you.
Thank you so much, Nishant, for that kind introduction, and I hope you're able to see my screen. Yeah, so I'd like to join my colleagues in congratulating you on this 3rd anniversary of PMJ and all of these tremendous accomplishments and really, really deep work to advance towards universal health coverage through PMJ. We've been talking today about a forward-looking approach to upgrading the provider payment systems for hospital inpatient services. Of course, that's the focus of PMJ. But I want to pick up on the last bullet point in your presentation, Nishant, really forward-looking, looking at advancing UHC and looking across the continuum of care. And what does that mean to actually provide coverage across the continuum of care and to pay for that well? I think it's a very important part of ensuring the financial sustainability overall of PMJ, making sure that the population has access to all of the services they need, and to making sure that that is delivered in a really efficient and high quality way across the continuum of care. So I wanted to share some reflections today about how you might want to think about that well into the future. And I'm hoping that we have. So just to frame the conversation, thinking about how we might look at provider payment systems and incentives across the continuum of care, there are some questions that you want to be thinking about. Do the payment systems work together to create the right incentives to deliver the right services at the right level of the system? I think that's something that Jack mentioned in his presentation. To be most efficient, we want to make sure that care is delivered in the most efficient and effective part of the system, the most cost-effective part of the system. But there might be incentives built in that might motivate providers to shift services to other parts of the system that have more advantageous payment systems. And then we want to ask ourselves, which part of the system might be internalizing the costs of these inefficiencies if the payments aren't working well together? So as we look at what's happening, to keep these 3 questions in mind and try to better align and get services at the right level where people can access them most efficiently and most effectively. So what do we typically see actually when we look across levels of care, look across the continuum of care? What kinds of payment systems do we see, and what kind of challenges does that create? And what we often see is that at the primary healthcare level, there is what we call a closed-ended payment. So primary healthcare might be paid by a budget or capitation. So each provider has a limit in the amount of revenue they're going to be able to take in a year. It's closed-ended for that provider. Whereas at the level of outpatient specialty services or inpatient services, we often see open-ended payment. So one provider can continue to bill. And that might be a fee-for-service, or DRG can be open-ended package rates that one provider can keep billing. And of course, that creates a set of incentives in the system that causes a number of issues. Under a closed-ended payment system, primary healthcare providers might have the incentive to over-refer or under-provide necessary care. That then leads to unnecessary hospitalizations. Cases show up in hospitals that could have been managed more cost-effectively at the primary healthcare level. That, of course, leads to higher costs and often lower quality. And so that has negative consequences both for the insurance scheme, for the purchaser, but also for patients and their higher out-of-pocket costs, which has negative impacts on equity. So what can we do about this? As we start thinking about aligning payment and incentives across the continuum of care, you want to think about two things. First, you want to think about that open-ended payment, that what can you do about that? And both Jack and Karen mentioned in their presentations that as PMJ thinks about moving towards DRG payment, you want to think about that in conjunction with a global budget or some kind of capping, some kind of way to make sure that there isn't open-ended payment at the inpatient, more expensive level that lives together with closed-ended payment at the primary healthcare level. But the other thing you can do is also look at sharing incentives across the continuum of care. And I want to talk a little bit about some options there and what's happening in Indonesia, where I have been working, where they are taking this issue on in their national health insurance scheme. So what's happening in Indonesia? I'm going to take a particular case of tuberculosis diagnosis and treatment, because this is where they're really starting to look in Indonesia, looking across the continuum of care and trying to align incentives and payment. They're also doing the same for maternal and newborn health and maternity services. But I'm going to focus today just on the situation of TB, where we have some concrete data to share, looking at the magnitude of the issue and what can be done. So in Indonesia, they have this classic situation where primary health care is paid through closed-ended capitation, and hospitals are paid through what they call INA CVGs, which is really akin to the package rate payments in PMJ. And this is the case for TB. For uncomplicated TB cases, the primary healthcare providers should be diagnosing and managing these cases, treating them under their capitation payment with no additional payment. However, if those cases are referred to the hospital, they're paid through this package rate, but they can have actually multiple billing, multiple charges for different parts of TB services for one case. And so a study that we worked on with our colleagues in the Ministry of Health and the Purchasing Agency in Indonesia, BPJS, found that in fact, all of these expected behaviors on the part of providers are being observed, that the primary care providers are referring a lot of uncomplicated TB cases to the hospital, even though they are supposed to be treating them within their capitated payment. We see a lot of those cases could have been managed at the primary care level, but the hospitals retain those cases and continue to bill for them because they can bill in an open-ended way. And this has had quite an impact on the costs for Indonesia's national health insurance scheme. If we look at these bars we're looking at public primary care providers, private primary care providers, and in total, the referral rates for uncomplicated TB cases. And in the public sector, 27% of uncomplicated TB cases are referred. Private primary care providers refer 56% of their cases. And in total, about 40% of uncomplicated TB cases are referred. And we consider these inappropriate referrals that should have been avoided. And that has a very high cost to the system. In 2020, about $12 million to the national health insurance system in Indonesia. And that's just for TB. So if we look across all of the cases where we're seeing these incentives at play, leading to inappropriate referrals and high cost hospital services, it's really quite costly. And private providers are even usually more kind of responsive to these incentives in the system and see the financial benefits of referring and do that even at a higher rate. So when there are more private providers in the system, we see these incentives actually have more consequences. And none of this takes into consideration the cost to the patients, that those out-of-pocket payments that are much higher when they go to the hospital when they don't need to, they're paying more out of pocket, and that of course has equity implications. The same thing is happening in Indonesia on maternity care. We're seeing the same incentives play out as antenatal care is covered at the primary care level through capitation, whereas deliveries are paid through the package rate to the hospitals with a very, very high rate of cesarean sections at a cost to the system, cost to the patients, and of course, implications for quality. So Indonesia is now looking at different ways to pay for these services to try to look at the incentives across the continuum of care. They're designing new models of payment that are episode-based payment. And this is looking at all of the services for one particular episode of care, for one case of TB, for one pregnancy, all of the diagnostic primary healthcare services if hospitalization is needed, and then post-hospitalization for a fixed period. And this is a trend for some kinds of services that really are a high cost to the system, where we think that quality could be better if incentives were better aligned across the continuum of care. And this is one option for this forward-looking piece for PMJ to think about. And just to give some evidence and examples that we're seeing how this can be done, a lot of this is happening actually in the United States. There are a lot of pilots for episode-based payment in the United States, and we have some good evaluations of them. And just want to share one example. And this is for pregnancy care in one health services system in the state of Oregon. And they're finding a lot of fragmentation for maternity care, high costs, and a lot of what they consider to be unnecessary cesarean sections. So they outlined some service delivery objectives that they had for this episode-based payment pilot, and that is to link service delivery with clinical standards, to try to push service delivery to the right level of care, to have more done at the primary care level and with midwives instead of obstetricians. So they designed a service bundle that included all of the necessary care, including prenatal checkups, support, labor and delivery, and postpartum care. Excluded what they considered to be outside of that normal package, outside of their objectives, and high-risk pregnancies were paid separately. They contracted with nurse midwives, specifically designating this contracting entity. In Indonesia, where they are implementing something similar for TB services, they did not limit, they are paying both primary care providers for uncomplicated TB cases, but hospitals can also deliver the services, but they will only receive the same episode payment as the primary care level to make it less cost effective for them to do that. So this payment bundle then is calculated and paid for one lump sum payment for the entire bundle of services for the pregnancy episode. And quite good results have come out of this particular pilot. They've seen the cost per pregnancy has gone down about 10%. C-section rate has gone down to what they consider a more appropriate level, about 9%, 19% of pregnancies, and with a really high degree of patient satisfaction. So this is one way to start to align incentives across level of care, either for one provider who is delivering across the continuum, or for multiple providers who are delivering the services across the continuum of care. We see some evidence that are coming out of the evaluations in the United States, but elsewhere. We find that these episode-based payments are typically limited to certain conditions or procedures or treatments. So they don't have a widespread impact on the system, but they are an entry point to start thinking about how to better align incentives and to look at the whole continuum of care and how providers work together and where the incentives can make them work better together. The studies that are available are showing some promising impacts on costs, lowering costs, sometimes quite significantly. In one case, a 34% savings for joint replacement episodes in Sweden, less of an impact on the elderly population in the United States for more complicated conditions, but still some cost savings. And some small but positive impacts on quality as that continuum of care is looked at more holistically and incentives are created to move services to the right level and to encourage providers to work better together across the continuum. But there are some challenges, and really this is a very difficult direction to move in if you have fragmentation across your benefits packages. If the packages themselves and the financing is fragmented, it's much more difficult to create this kind of a payment system that links across. And it might actually be impossible, but it's something to think about. Defining the episodes of payment can be difficult, especially for chronic conditions, but it's a really important area to continue to look at as we see the costs and quality problems of fragmented care and perverse incentives for chronic conditions. So I think this is a new emerging area that deserves a lot more attention and evidence to be generated. There might need to be risk adjustment, that one episode is not the same, even if we exclude some of the very high risk cases as they did in the maternity care pilot in Oregon. There are still variations for patients and their risks, and of course then the cost to the providers that may need to be accounted for in the payment system. So just to come back with a few messages for you all to think about as you look ahead for the paying providers across the continuum of care in PMJ to really be holistic, to move towards USHC, to get the right incentives in the system to deliver services at the right level. These are really important things for your financial sustainability, but also for quality and equity. That harmonizing, if you fail to harmonize, there will be hidden costs. There will be cost shifting, even from parts of the system that aren't currently included in PMJ. This can be quite significant over time for your own financial sustainability, but also for the burden of the beneficiaries and the equity. And there will be definitely impacts on quality and efficiency across the continuum of care. There are some options. You need to look at multiple options to start to address this issue and take it on, start to looking at what it means to have closed-ended payment for your inpatient services. What does that mean for how you think about moving forward with DRGs? But then also looking at some really important kinds of conditions and services that you might want to single out for an episode-based payment that will have big impacts on costs and quality. In Indonesia, they're starting with TB services and maternity care. That might be different, of course, in India, but can you pull out some of these episodes that could have high impact? Are there other ways that you can share accountability and incentives across the continuum that might not be just limited to payment, but some other kinds of monitoring and accountability? And really thinking about the consequences, the hidden consequences that some of this fragmentation of the benefits might have, and can you think about ways to deal with that earlier, even before you can think about integrating payment across the continuum? So these are just some forward-looking thoughts and reflections for you as you think about the continuum of care. And also now, early on, as you think about designing your DRG system, you can already bring in some of these elements and reflections. So very best wishes, and thank you again for this invitation.
Thank you, Cheryl. And I think it was an excellent presentation with very interesting idea of episode-based payment. I think we'll come to that in Q&A also. So now it's my pleasure to introduce Calypso, and Dr. Calypso Chakidou. She is a dear friend, but she is one of the global experts on this field. And also, she's founding head of the Global Fund's Health Financing Department. So something she's doing, I think, very interesting job sitting in Global Fund now. But before that, she was the director at the Global Health Policy and a senior fellow at the CGD. And before that, she was at Imperial College. She has been involved with the Chinese rural health reform and also in the national health reform projects across the countries, including US, India, Colombia, Turkey, and Middle East. She has worked with various other organizations in the past. And she's also a visiting professor at Imperial College and King's College. So I'm very happy that Calypso is able to join us, and we are very happy that she will be able to share her thoughts with us. So Calypso, please. Thank you.
Thank you very much, Nishant, and it's a great pleasure to be here virtually, and a very happy third birthday to you. My colleagues have covered everything that I think is important and is worth sharing, and I will just focus on the parochial experience of the National Health Service in the UK, and try and connect back to some of the key messages that my colleagues have already highlighted. First of all, to say that it is a journey, as you've said also in your opening remarks in your presentation, Nishan, it's a journey. In the UK, in England, in the National Health Service, it took it more than a decade to transition to the HRGs, the DRGs in the English system. And over the years, it's been a gradual process, managing risk, refining, improving, and conditioning to the setting in the NHS. And you can see progressively the value of activity, and now it's a bit over 50% the activity, hospital activity covered by payment by results. In fact, there's been a bit of a reduction, and all this to show, I think, how important it is to be flexible and to test out different modalities and to be able to adjust. So it's not a one-way street. Things could well change. And this, again, to flag that specific aspects, and Cheryl and others mentioned that, of care, it's taken even longer to integrate. So, for example, mental health and maternity services, or diseases such as cystic fibrosis, or caring for people, young people with diabetes, more specialized services, were not introduced in bundles of care or mental health clusters until 2015. And even now, there's a progressive realization of the vision to include everything in the DRG and create those bundles that are meaningful and adaptable. Oops, let me see if I can move to the next one. So whilst this journey is taking place, I think it's well worth enjoying cherishing the journey, because it is important. During that journey, a number of byproducts are very important, were generated, including better data, including a culture of stronger accountability between the provider and the payer being more able to be more strategic, to be more forceful, to be more aware and smarter in terms of what they're asking their providers to do, and the providers being well incentivized to respond, and the whole system being able to performance manage for the key priorities, which again, based on the difficult political policy priorities, change year on year. So the information systems that were built around the pay for performance, the payment by results system in the NHS were really complex, but at the same time really useful for informing all sorts of different reforms and arrangements in different parts of the system. And of course, India is well ahead there in that you have a very well advanced digital system, a set of dashboards that already give you a very useful information. This is for the National Health Service, which was never been an insurance system. So introducing payment by results and the DRG system allowed us to get some sense of what people were doing and what the Department of Health ultimately was paying for. So that was really, really important. Hospital episode statistics, a large database that codes, records, tracks activity in the hospital sector was set up, which again was quite powerful. A whole effort on costing. Jack mentioned the importance of costing as a core element of building, a core building block for the DRGs. And indeed, the NHS has made significant strides in costing. And I know that NHA has been really driving the agenda of costing in also different ways. So the methodological elements of developing costing approaches, but also making them feasible and practical and applicable, and engaging providers to bring them along that journey for being part of the costing effort. Costing is so critically important. And indeed, I think now the National Health Service has a really strong unit driving costing across the whole of England, across hospitals, providers and commissioners of care. And progressing the costing agenda. Now we're very much the patient level information costing system, the PLIX data, which aims to be more refined, more granular, more specific to activities. All that to say, again, it's a journey. It's a journey of continuous change and refinement. And that's in itself very important. And then integration, and Cheryl mentioned that earlier, but what DRGs have also helped do, and the data, the information that has come with the reform, is to acknowledge how important the care pathways before patient reaches the hospital, and also what happens to them afterwards. And now we're seeing really serious efforts, and the NHS have been trying for years to do that, but I think now the efforts are really more serious than perhaps before to integrate social care, local governments, bring budgets together and get providers of care in different settings to share in the risk in taking care of individuals with different problems in different settings. And you can see this includes social services, local governments, the NHS clinical commissioners, also NHS providers. And it's quite important, I think, public health and prevention. And this, I think, would not have been possible had we not embarked on the DRG journey to some extent, generate all this information and tried then to improve efficiencies and monitor quality at the same time. Because, of course, a lot of things happen outside the hospital and we pay for them, the system pays for them. So looking upstream and downstream, prevention, primary care, community care services is absolutely critical as you're reforming your system. And I'll finish with reiterating the points, one of the points at least I made earlier, that India is well ahead of the game, certainly ahead of where the NHS was when it started the journey towards DRGs. India has a fantastic digital health infrastructure. Your dashboards are absolutely amazing, real-time, accurate, flexible, adaptable, evolving. You're starting, as Nishan said earlier, from a fixed package rate regime, which is quite important. So this is not a fee-for-service system that you're trying to shift. So the risks are perhaps more easily manageable, and it will be perhaps politically also more feasible to move in that direction because you've already started. You do have a commitment nationally to track and reward quality. And I think that's again, is very important with the PMJY. That's become absolutely obvious that quality matters. It's not about accessing care, but it's good quality care. You care about what service users think, and you have ways of tracking and giving them a voice. And that's absolutely critical, I think. But I think ultimately what's also very important is what you do, what you develop, and this become apparent from my colleagues' presentations, the wealth of information from different countries, that ultimately it needs to be a solution that's fit for purpose from India. Pick the things you want from other settings, don't reinvent the wheel, of course, but at the same time, you must make sure, and I think you will do that, you're doing that the solution is very much a solution that's specific to your needs. And your circumstances. And with that, I will stop, and I look forward to the discussion. And thanks very much for having me. Thank you.
Thanks, Calypso, and thanks for this nice visual, which I believe is from behind of a truck somewhere in India. So it's nice, and thanks for your thoughts. And I think all the four presentations were complementing each other very nicely, and I think Jack, also thanks to you for your suggestions regarding rearranging some of these talking points. So it went on quite well, I will say. And, but the more we hear, the more questions comes into our mind, because they provide, these presentations provide information, but also they poke you, to understand and know a bit about more. So maybe I'll start, Jack, with you. You gave a nice picture, Jack, of how things started happening, and what could be the phased approach which needs to be taken. But for any country, and especially when we talk about India, if we want to embark on this journey, what do you think are preconditions which should be there, in an ideal world for any country, and specifically for us, that you say that you have to do these 1, 2, 3, 4 things before you say that now we want to do, for example, DRG. So what could be those things, and what could be the answers to those things? Thank you.
Thanks, Nishad. So there are always preconditions when you're thinking about what I would call strategic purchasing, right? So first and foremost would be your IT platform. And I completely agree with what Dr. Calypso was saying. You have a very sophisticated, advanced IT platform. And, I don't worry, if there's one country in the world I don't worry about in terms of IT, in terms of IT infrastructure, in terms of capacity, it's not, India is way ahead of everyone else. So here, I think you're in good shape, and you're going to have to look to see if there are missing elements that you might build into your claims processing system. But the last time I looked at your claims form, it was very advanced and it was very good. So I think that here, your precondition, your IT system, maybe you'll need some changes at the margin, but I'm not worried. And in terms of human resources, you have the people. So that's number one. A second area would be autonomy in the public sector. So as you move to more sophisticated incentive payment systems, your public providers will need more flexibility to respond, right? And you want them to respond. That's why you're developing these incentive payments. You want them to respond. But a CEO at a public hospital, does he or she have the opportunity to close beds, to open beds, to hire different types of people, to buy different types of equipment? You know, often in public systems in any country of the world, it takes a year or 2 years to get the okay. And they're often stuck with line item budgets through their other mechanisms, their other revenue sources. So I think autonomization is a big issue. I know that the UK is a good model in terms of how they move from a relatively rigid public provision to autonomization and corporatization. So, you know, in the UK, it says we are a community hospital, we are a public community hospital, but when you walk inside, it's managed as if it's a private institution. So that's a good story, a good lesson, a good model that we can all learn from. And then I think a third would be quality. And here again, I think Dr. Calypso has very nicely talked about the advances you've made in terms of quality assurance, quality metrics. And then I think a fourth would be the monitoring system, because as you move to more sophisticated payment systems, we like to say in the United States, there are unintended consequences. That's a nice way of saying there are going to be surprises. And there are slightly different surprises in every country, depending on what that model looks like. So you will need a monitoring system to identify and address and correct the so-called unintended consequences. So those would be the preconditions, the 4 preconditions I would place before you. Over.
Thanks, Jack. And I think you're absolutely right. This unintended surprises, many times they surprise you more than what you think. And in a country like India, with such vast and diverse country, these things becomes more interesting, to be safe to say the least. So maybe I'll come to Karen now. Karen, I think it was very nice to see this 2 examples you showed from Germany and Estonia, how the phased approach was taken, and you know how they moved forward with this kind of phased approach. But when we think of a country like India, where we talk about maybe 25,000 hospitals, which we have now, and half of them are public, half of them are private. So if we have to take a phased approach, of course, we can't do overnight. We have to take a phased approach also if we do something here. What kind of approach you think could be more appropriate in our context, at least from your whatever understanding you have? Like, for example, one thought which we were discussing that, you know, whether we start with public hospitals or private hospital or a mix of both, or a geographical phased approach. So do you have any suggestions on those lines that when we think of phasing, what could be the ideas? Thank you. Karen, please.
I think this is a very challenging question to answer, in fact, because it would be very important to know the details of current payment systems to try to figure out what is most appropriate. And there's also a political element to this, right? Because there could be a number of like technically appropriate and feasible pathways, but your hospital administrators may not have the appetite to move in that direction. So I think the development of the phase-in strategy needs to be something that's widely consulted by your DRG team. And I would like to come back to this question of the DRG team or unit, because these must not only be people who are technically strong, but they need to be people who are effective in communication and are empowered to do stakeholder consultations and reach out more broadly, so they can ensure that whatever solutions are reached are not just technically appropriate, but also politically acceptable and politically feasible. I'm just wondering whether to continue in more detail or just leave it.
Just a follow-up point.
Now. And I think in the terms of the phase-in strategy, to have the budget neutral phase is exceedingly important. So to simulate, for example, what revenues might be under DRG system and to be able to compare it to what hospitals have now, so they can start to adjust their clinical practice. And so that could be a first phase that hospitals could work on, and your system could work on, even as you still start to figure out what the phase-in of your payment strategy may be.
And just a follow-up question, Karen, on the same lines. Do you know any country where they have done this phasing based on public versus private kind of hospital, where they started with only public or only private, or they always start with whatever they have, even if it's a phased approach?
It's a really good question, and I'm afraid I cannot answer it. So let me also ask my fellow panelists whether there's any particular example that they can bring. You know, I think the principle should be, you know, sort of equity within the payment system, and such that all of the providers who are contracted to provide services are brought in together. But let's see if there are any other examples.
I think Jack had something on this. Yes.
Thank you, Nishant. Yes, I'm working with a GCC country right now, which will move, they will have a phase-in process where they will move first to the public providers. It's a relatively risky approach because the public providers don't have a lot of autonomy. So it's a relatively risky approach, but nevertheless, the political decision is that we really need to reform our public sector system. And so let's start there. And you know, it's a market signal for them to start restructuring and rethinking the way they do business, the way they provide services. And then later they will go to the private sector. But you know, I have to say that the private sector always responds very, very quickly. They get it. They look at how the DRG system works and they start responding overnight. In the US, we saw a massive turnover of types of nurses that hospitals were letting go and also hiring. They were hiring much higher, much more highly trained technical level nurses when they went to the DRG system because they wanted to be more efficient. They wanted people to get in, get good care, and then be discharged. So I don't worry about how the providers and the private sector will respond. They will get it and provide and respond quickly. And I think you'll need to give the public sector a little bit more time. Over.
Thanks. I think thanks, Karen, and thanks, Jack, for adding this extra bit. I think this is something which is very critical. I think this whole autonomy of the public hospital issue, which is there, because you know when you start working with them, and if there is autonomy is not there, then yes, they are more constrained and they take more time, maybe some time to adapt to things. And as Jack rightly said, private sector responds fast. But you know, in our case also, the private sector is not a monolith. You know, it varies from 10-bedded hospital to maybe 1,000-bedded hospitals, and that is a further complication, which of course other countries also must be having. But we also kind of see that. So Cheryl, maybe I'll come to you. You know, I think it was great that you brought this whole idea of going beyond just talking about DRG and this suggestion of episode-based payment. I think this is very interesting because, you know, though we are not doing anything on that right now, but this gave a lot of food for thought. For example, right now there are national programs like National TB Control Program and all, where they pay from those programs, and also we pay from PMJ, from our insurance scheme. And this kind of episode-based payment maybe can bring those things together. We can try to see that how it can come together actually. But again, that gave some questions in my mind. For example, if the service is distributed across providers, then how do you distribute the payment and how do you fix the accountability? You know, that if two providers are providing as a part of the same service, part of different things. And then how do you do that? And there must be some ways in which US and other places are doing. So Cheryl, please. Thank you.
Thanks for that question, Nishant. I think what we find, there are two situations that we have encountered with the episode-based payment. One is that the services are being paid at the wrong, or they're being delivered at the wrong level, and you're trying to incentivize a shift. So that was the case for TB in Indonesia, that we're really trying to get all of the uncomplicated cases to be diagnosed and treated at the primary care level. The other is the situation that you've mentioned, that actually we're talking about multiple providers and we need to bring them together and working together. And that also means sharing payment. And that's really the situation for the maternity care services in Indonesia, where you have private midwives, public clinics, and also public and private hospitals, and trying to find a way to bring that continuum of care together and make a payment that links. And in that case, they're talking about forming networks. So bringing the providers together for this particular issue and making a network where they are having some kind of a financial arrangement together. And right now it's really only possible between the private midwives and a public clinic. So it's not that easy, but it's a first step. And it's a really important conversation that they're having. How can we better leverage the public and private providers for different points along the way in this continuum of care? Whether or not it's possible to have those kinds of financial arrangements and contracts is really very context specific. This is something they tried in Ghana, tried to form networks across at least primary healthcare to be able to deliver the whole package and make one payment for a population. They weren't able to do that yet. It has been impossible to have contracting arrangements between public and private providers, but it has at least fostered the conversation and has taken that forward.
Thank you, Cheryl, and that helps to make me understand a bit more. Maybe Calypso, I'll come to you. So, you're right, absolutely, that when you shared the example of NHS, that in India, we are starting at least from somewhere, not from zero. But it's a federal country and health is a state subject, so in that sense, we have to be cognizant of that fact, that how do we work across the country and how do we do that. But another thing which came to my mind when you're talking about experience of UK and how it is a journey and it's taking so many years still and it's continuing, the reaction of the hospital because in UK you started from fee for service and going towards DRG, it was a big change for them. How did they react in hospitals, and were there a lot of meetings which were done with the hospital before this thing was implemented? Or you started in a phase where with small geographical area and then you expanded slowly and the hospital were broadly okay with that? So what was the interaction with the healthcare providers? Calypso, please. Thank you.
Thank you. I think I don't think it was an easy one. I think, and as Jack mentioned earlier, the provider sector in the English NHS has changed quite significantly over the years and was moved towards a more sort of market-oriented, more autonomous, less risk-averse environment. And that's been a tricky journey. I think the political commitment was there to make the transition, but it took a long time, and this reflected to some extent also pushback. And it's a fine balance to look at the risk and basically how much of the risk, who bears the risk as this transition happens. Whilst there's more money in the system, this is a positive, but as money becomes scarcer and there's pressure to improve efficiency. So from one year to the next, the government will say now any emergency admission over and above the average of the past 3 years will be paid 30% less. So that's a big pressure on hospitals not to admit and to work also with communities to prevent emergency admissions of things like, asthma attacks or diabetes. So you want to get these people who suffer from chronic conditions to be well controlled outside. But this change in mentality, so that hospitals felt the pressure, felt the need to reach out and work with the community providers, with the GPs, general practitioners, that started to care a bit more about the health of the population, trying to understand who if you like, the more sort of frequent visitors to the hospital that drove costs up were, and try to prevent those episodes. This was a lengthy process. In parallel, though, as Jack said, hospitals in the UK and England moved towards foundation status, which meant they started to be able to borrow money to some extent. They were a lot more accountable for balancing their budgets. The CEO, the chief executive, would become a lot more vulnerable in a sense if the hospital didn't perform well. So it wasn't business as usual. Things changed, and it was part of governance, and it was part of contracts and provider payment, and it was a journey. But I don't think it was an easy one. I don't think the hospitals immediately said, "Oh, that's wonderful. Let's do it." This was there's a whole generation, older generation of NHS managers who felt that their role was very different from managing budgets and managing risk and planning in that way. So it wasn't an easy transition, but and still I think there's issues. But I think, just to finish, the fact that the transition happened also through reference costs. So initially it was about collecting information, trying to understand what the averages were. I mean, even asking that question was a big one, because we don't have a billing system, so hospitals didn't know what they were spending. So just starting to understand in big groupings, on average, what are we spending for cardiovascular care? It was a big departure in the thinking, and then it became more refined and more granular. And then the pressure started on how much actually they would get paid for certain procedures. So to incentivize daycare, to incentivize prevention, to reduce emergency admissions, and so on and so forth. It was a change in culture, and that's why it's taken. It's still ongoing, I think, this process. Thank you.
Thanks, Calypso. Thanks a lot. And I think, yes, it's not a simple process. And I think this whole idea, when you started collecting data itself, was a big step, because in India also, I think that's a challenge. We have some data based on our scheme claims and all treatment, but a lot of other data which we don't have. And when we start thinking of collecting the data also, it's not easy, because even if hospital has some data, they will not always be very happy to share it easily, not all the hospitals. And both at public and in the public itself, it's a much more challenge, because they don't know many times the costing part, and it's scattered, and many costs are hidden, which you can't see very easily. Then you have to dig deep. So yes, I think it's very interesting. Anybody has any panel member, if you have anything you want to add right now, because we are a very good panel, we are absolutely on time. So if you think that's something you wanted to mention earlier, which you missed somehow, Jack, please.
Yes, Nishan, at this point about some of the hidden subsidies on the public side. Yes, one of Karen's World Bank colleagues, IJ Tannen, who's actually sitting now in Delhi and who is recovering from COVID. I'm so happy that he's doing quite well now. He did have a bout with COVID, but he's doing quite well. I saw him just the other day, and he did some estimates on some of these hidden subsidies in Indonesia, since Cheryl had talked about Indonesia, and he found that the vertical programs and some of the hidden subsidies, or some of the more explicit subsidies such as capital, amounted to about 60% of their revenues. So when you want to think about integrating public and private delivery, and you want to think about making the playing field level, then you do have to really hone in on what's going on there. Your other point about the small private hospitals, that's a very interesting point. And I think that because DRGs use averages, that will probably push the private hospitals to rethink their size. And we saw this in some other countries. Some of the smaller hospitals don't do as well as some of the medium-sized hospitals. And so when you look at cost structures, you find that a bed size of 300 to 500 is probably your best cost structure going forward. And so the DRGs will probably encourage some consolidation, some restructuring of the private sector as well. And that could be very good for both efficiency and for quality, because there you'll see some volume effects. Private and public hospitals will start to focus on where they're good And they will build some, they may build some surgical theaters to focus on certain types of cases. And there could be an impact, good impact, both in terms of efficiency and in terms of quality. So yeah, I think moving to these new incentives, these new payment models will shake up in positive ways to both public and private delivery. Over.
Thanks, Jack. And I think this is a very pertinent point, and it would be interesting if we really, and when we really go for it, because we are talking for a long time in India, that how do we bring some kind of quality standardization with the smaller providers also, and this may actually, with this consolidation, may help towards that. Anybody has any other point you want to add? Cheryl, Karen, Calypso?
Maybe one more point from me, Nishant. This is maybe tying together the DRG conversation with the continuum of care conversation. And I'd like to go back to what Karen said about knowing what your objectives are. And you can, if you actually have as one of your objectives for DRGs to improve the continuum of care and where services are delivered, you can actually make it work for you. And I think we saw in the US early on, right, Jack, that when the DRGs were implemented, there was a shift towards more ambulatory surgery, that it wasn't lucrative for some of the hospitals to deliver services on the lower end of the case mix. And so they got shifted to the outpatient setting. So if you have this as a deliberate objective to improve that continuum of care and bring that conversation in early on, you can really use this to your advantage and to shift some of the unnecessary hospital services. But you have to bring in the outpatient providers and make sure that it also works for them. And if you look at it holistically, you could also use DRGs to advance that objective.
Thank you, Cheryl. I think that is something which we also wish that we move towards that, this whole continuum of care approach, and including the payment reforms there. Any point from you, Karen or Calypso?
Perhaps just to note that DRGs are not primarily a payment mechanism, right? They're a classification system, and that there is tremendous value in using DRG classification, even without shifting to payment by DRGs. It's tremendously useful in benchmarking of care across hospitals, looking actually within your current provider payment system of how horrible hospitals that may have a similar case mix, in fact, receive different levels of revenue, and perhaps could therefore be providing care in a more efficient way. So I would encourage introduction of DRGs, even simply for quality and benchmarking purposes.
Thanks, Karen. I think your book will really help us, because I think we were just going through it, and it has very interesting learnings, I think, which people are really trying to understand here. So you're absolutely right that the payment is one part later, but I think before that itself, it's a very important tool. Calypso, you want to add anything in the end?
Not really. I think, just to wish you the best of luck, Nishan, and your colleagues. And as always, lots of people are watching what India is doing. So best of luck and a very happy birthday.
Thank you very much. And so let me officially thank all the panel members. And it was an excellent panel. We're exactly on time. And more than the time, I think it was very enriching discussion for us. And the good thing is that we have been able to record it. So a lot of people from our team who are running here and there for this event, they will also be able to listen to it later on. And also for the people who are not here present, we can use part of a lot of this discussion. We'll come out with a report also for each panel discussion and for each session. We'll share with that, and we will look forward actually to engage with all of you and maybe your colleagues as we embark on this journey in future, because I think this will not be a small undertaking. And when we move towards these reforms, I think this will need a lot of support for us. We will need a lot of support from all of you. It will not be an easy task, but I'm sure it will be quite thrilling for us. So thank you all of you. Thank you for your time, and good afternoon, good evening, good night, good morning, wherever you are. Have a nice day. Bye-bye.
Thank you, Nishant. Well done. Bye-bye.
Thank you.
Bye.
Bye, everyone.
Thank you, and all the best to you.
Bye.
Thanks.
Yes.
मेरे लैपटॉप में 1% बैटरी बची है.
Thank you so much, sir. Sir, thank you so much for guiding for the session since beginning. And कोई glitch भी नहीं आया. It was like sir, I think Sankal.
कल एक नहीं कल शाम को इंडिया से बता दिया ना. पहले एक संकल्प वो वाला ये मिसिंग मिडिल वाला और फिर बाद में इंडिया वाला.
Sir, can we have a picture?
हाँ.
Since we are doing this outside.
Care पे तो एक